Hey everyone, it's Kim. My presentation is going to be on Parkinson's disease, and this kind of hits home for me, so I do plan to do some more research going forward, as one of my close friends in her early 40s was recently diagnosed with Parkinson. So for my case study, I have a female patient. She's 53 years old with a chief complaint that her work performance has declined because my tremor makes it difficult to type on the computer and I'm slower with most tasks. She presents with mild tremor to the right hand, and that's become more intense over the last 6 months. This is her dominant hand. She also states that she's taking longer to do things because it requires more effort to start her movement, and she's also reporting muscle stiffness. She's complaining of some difficulty staying asleep at night, constipation. She's lost her sense of smell for about the last 2 years. She's had decreased libido for the last 8 months, and night sweats and irregular menstrual periods for the last year. For her history, her past medical history is hypertension for a year and then a broken left wrist after a fall 2 years ago. She denies any alcohol or tobacco use. Her family medical history includes her mother, who was deceased at 89, secondary to complications from a hip fracture, osteoporosis, and Alzheimer's disease. And her father is deceased due to an ischemic stroke. This patient has 2 daughters. They are both in good health. And she's been married for the last 23 years. She does deny any other autonomic dysfunction and denies any psychological problems such as anxiety or depression. Her current medications are verapamil, 180 milligrams every morning for a year, and calcium carbonate, 600 milligrams of PO every morning and night. On examination, her vital signs are within normal limits and her labs are within normal limits, which is generally the case with Parkinson's disease. She does show a small amount of dry yellow scales to her eyebrows. She has decreased facial expression, decreased eye blinking, and on the Hamilton Depression, which is the HAM-D scale, she's 3 out of 66, and that's just due to the sleep problems and the libido problems. The scale that's used most frequently to diagnose Parkinson is the Unified Parkinson's Disease Rating Scale, or UPDRS. She has a total of 19, and that's using the 3 parts. There's actually, it can go up to 5 parts, but in this situation we just needed 3. And that's, part 1 is fermentation, part 2 is for ADLs, and part 3 is the motor exam. As a side note, her handwriting does show micrographia, which is small writing, and that's common with Parkinson's. She doesn't have any issues with her gait or posture. She does show right-sided rigidity. She has a tremor and some fine motor coordination issues. Based on these findings, she was diagnosed with early, a mild stage 1 Parkinson's disease. It's classified at stage 1 because it's limited motor dysfunction. It's only on the one side, the right side. Parkinson's disease is complex, and it's not just limited to the classic motor symptoms. There's also quite a few non-motor symptoms that can show, and they should both be considered. The non-motor symptoms, and in her case, that would be the constipation, the decreased libido, the loss of smell, and so on. They can be seen several years before the motor symptoms. In her case, like I said, the complaints of the sleep disturbances and the constipation, the loss of smell, and libido issues are all typical non-motor symptoms with Parkinson's, and they can show up 5 to 20 years before the motor symptoms. So those, coupled with the motor symptoms of tremors, the bradykinesia, and stiffness, make this diagnosis clear. Parkinson's disease is complex. It involves motor function, non-motor function, and neurologic symptoms. And the main feature is the degeneration of the basal ganglia, which results in disruption of dopamine secretion. Parkinson's is classified into two categories, primary and secondary. Primary is the most common form of Parkinson's. It's sporadic and it's often genetic. The onset generally occurs after 40 years of age, but it's most commonly seen in adults over 60. So it's considered early diagnosis, in the 40s and the 50s. Parkinson's affects approximately 2% of the population of North America over 60. It was initially described by James Parkinson, hence the name Parkinson's, back in the early 1800s. He noted even then that this disease wasn't just characterized by the obvious motor symptoms, but that many patients also presented with some of the non-motor symptoms. That list has actually grown as time has gone on. Like I said before, you can see the non-motor symptoms as early as 5 to 20 years before the motor symptoms. The pathogenesis of Parkinson's disease is unknown. However, there have been genes identified that are typical with Parkinson's patients. The loss of the dopaminergic neurons and dopamine deficiency, which is the hallmark in the Parkinson's patients, causes sorry, I need to go back a little bit here. Causes underactivity of the direct motor pathway and overactivity of the indirect motor loop in the brain. And this inhibits activity of the motor cortex, which is what causes the bradykinesia and rigidity. The overactivity actually influences the limbic system, which contributes to some of the psychological signs and symptoms. So classic motor manifestations would be tremors, bradykinesia, muscle stiffness, and postural issues. The classic non-motor symptoms are loss of smell, sleep disturbances, depression, autonomic dysfunction, and pain. The diagnosis is generally based on presentation with classic motor symptoms, but the non-motor symptoms can be present well before and can help with early diagnosis. Normally, the initial clinical signs will appear after degeneration of approximately 60% of the dopaminergic neurons of the substantia nigra. Parkinson's is progressive and ultimately leads to decreased activity, which can lead to increased falls and even cognitive impairment. So the goal of the treatment is to replace the dopamine levels with oral medications. This is done with dopamine agonists and dopaminergics. Some of the current treatments would be levodopa, which is pretty common, dopamine agonists, monoamine oxidase B inhibitors, anticholinergic drugs, and amantadine. Amantadine is actually an antiviral, which acts as an antidyskinetic, and so that can help treat the motor symptoms that are associated. Levodopa is generally the first line of treatment, but it is shown to cause increased motor dysfunction over time, and sometimes the complications are even higher in the younger Parkinson's population. So it's not always the first line for the younger or the early population. In addition, obviously, it's important to incorporate non-medication related therapies. There are exercise therapies that can help improve motor function and then just increase confidence. Treating symptoms that aren't expected to subside with the targeted therapy should also be considered. So for my patient, after discussing the medication treatment options, and then we researched the medication costs associated with the dopamine agonists, we decided that she should begin ropinirole or Requip. We did not go with the levodopa as she is in the earlier stages, and we thought we would start with the ropinirole and see how she does. So Requip is actually done in an ascending treatment fashion. So she'll be starting at 0.25 milligrams orally 3 times a day for a week, and then increases by 0.25 milligrams every week up to a total of 1 milligram 3 times a day in week 4. That's assuming that she's able to tolerate the medication, but doing this ascending dosing kind of helps to wean her into, so to speak. Definitely want to add in like a Metamucil, 3.4 grams or a tablespoon in 8 ounces of fluid a day, and increasing her water intake to help with her constipation issues. We're going to follow up a visit within a month, if not sooner, depending on how she's tolerating the medications, to just monitor the effectiveness. Possibly add in hormone therapy for the night sweats and libido, but I would hope to see an improvement with the Requip. If not, we can discuss that. And then kidney and liver function testing is absolutely important because Requip can alter kidney and liver function, as many medications can. Her baseline was completely normal, and there's no other comorbidities that would be of concern, but we'll definitely continue to follow that just to be safe. I would ask the patient to document in a diary, maybe just a quick, at the end of the day, a quick note just to kind of talk about how her day went. Were there any unexpected side effects? What were her severity of the signs and symptoms for the day? Were her tremors worse? Were they better? Her bowel habits and her sleep patterns, so we can kind of just see an idea if there's any progression with this medication. And then absolutely would refer to physical therapy for specialized therapy targeting Parkinson patients. And then this is done just to help improve the motor function and increase their confidence. Falling is a big issue with Parkinson's later in the game, and so the more we can get their strength and their motor coordination better and build their confidence, the better they'll be. So current medications would be the ropinirole, the Metamucil, and then she was taking calcium carbonate at home as well as verapamil for her hypertension, as we previously noted. So we would continue those medications as well. No significant interactions were found with the addition of the 2 new medications, but I did find a possible interaction with verapamil and calcium carbonate, but she was previously taking those without difficulties, so we'll continue them unless there's any issues. As a side note, I think anybody with Parkinson's should definitely be followed by a neurologist, so it would be beneficial for her to follow up with a neurologist, and then for myself to coordinate with a neurologist for further recommendation. Maybe he's got some better treatment options that you'd like to try. Please let me know what questions you have, and thanks again. Bye.